and I'm going to discuss some of the basics of capnography that you can easily incorporate into your practice. Terms like waveforms and PaCO2 can make capnography seem a bit intimidating, so I'm going to avoid most of the complicated stuff and instead focus on the simple principles that make capnography really useful in the ED. Capnography depends on three things: the amount of CO2 in the blood, the heart pumping that CO2 to the lungs, and the patient breathing it out. Fairly straightforward. All you need to know about these three is that the PaCO2 is at least as high as your end-tidal CO2, but it could be higher. Low cardiac output means less CO2 gets to the lungs, and if the patient's ventilating at all, then some CO2 should be detected. Here's what a normal tracing looks like if you haven't seen one. The baseline is 0, because during inhalation, no CO2 gets to the detector because air is moving the wrong way, so it reads 0. Expiration starts with an upstroke as the dead space washes out. The top of the wave peaks at end expiration, and the value here is what the machine spits out as the end tidal measurement, and the wave drops as the next inspiration begins, the last part of the square wave. And there are three straightforward uses for capnography in the ED. The first is confirmation of intubation, and it works for extraglottic devices to make sure that they're ventilating as well. One aside, you can still use those colorimetric CO2 detectors to confirm intubation, but if you do, remember that there can be some CO2 in the stomach, so you need to count out 6 breaths and make sure there's a persistent color change after you count to 6. Also, these are just filled litmus paper, so if the airway is soiled with acid, you're done. So once your ED gets waveform capnography, throw these guys in the trash. Quantitative waveform capnographs, on the other hand, actually detect CO2 molecules, either with IR spec or mass spec. So it really approaches a true gold standard because you know there's CO2 getting to the machine. It takes a beat for the CO2 to get up to the machine and the waveform to register. It's just like that second after the adenosine starts working where you know the heart's going to start again, but it just seems to take forever even though you know it's only a second. But once you see that waveform go up and come back down, you know your tube is in. And if you get an intubated patient with AMS, just pop in the capnograph, bag once, you see a waveform, no more guessing. No messing around with trying to get repeat DL with the tube in the way if you can't see anything. Just pop it on, bag once. Next use is in cardiac arrest. There are three uses during arrest. First, because of the relationship with cardiac output, you'll see a big jump in end-tidal arthroscopy, so you can actually time your pulse checks better. And because it's actual output, not just an electrical rhythm, you can hold compressions without worry. Next, as end-tidal is dependent on cardiac output, it becomes a gauge of how effective your compressions are. It's real-time feedback. Plus, it helps you spot when the compressor is tiring out. Lastly, studies have shown that if the value is less than 10, 20 minutes into the arrest, the patient's not going to walk out of the hospital. One note, if you've got an advanced airway in place, no matter how low the cardiac output is, there should be a waveform with ventilation. It might just be one pixel up and down, but there will be something. If it's completely flat, your tube's not in the right place. Third, we can use end-tidal to monitor sedation. It's the easiest way to make sure that you know when your sedated patient stops breathing. It's great for monitoring any type of sedation, procedural sedation, pharmacologic restraint, or even patient-initiated sedation, which I imagine some of you see in your ED from time to time. There are commercially available nasal prongs that attach to most capnographs to put on these sedated patients, but if you don't have these, you can easily make your own by putting an angiocath and a nasal cannula. The trick here is not to attach the nasal cannula to oxygen because the wall supply will just totally wash out what's in the tube and you won't get a reading because it'll all be flowing the wrong direction. One of my favorite parts about using capnography during sedation is that because you're monitoring their patient's ventilation directly and you'll know when they stop breathing, if they're going to, you can use supplemental oxygen safely. That way, if things go south during your sedation, your patient's already safely pre-oxygenated if they need to be intubated. Just make sure you're using a separate mask or a separate second nasal cannula as an oxygen supply. Now there are some advanced technical things you can do, such as watch the wave for changing in shape like the shark fin that indicates obstructive lung disease, the fizzle showing an air weak, or hypopneic waves. There's also a debate about whether quantitative changes are useful in predicting upcoming apnea, but don't worry about this complex stuff. The best use is just to answer the simple question that you care about when you're sedating a patient. Is my sedated patient breathing right now? Just glance up at the monitor. The guy up top, breathing. The guy on the bottom, stopped. Done. That's all you need to do. So that's it. That's all you really need to know about capnography in the ED. It's the best way to determine if your tube's in the trachea. It's great to monitor CPR, and it's the best way to make sure your sedated patient is still breathing. Now, I've got one extra slot for a slide for the PK, so here's a bonus picture of my 5-day-old daughter, Juliet. Thank you, and watch those waveforms.